Thank you. Good morning, everyone. My name is Amr Mohamed. I'm a vascular surgery resident at Mansour University Hospitals. Today I'm going to present our work, single tibial angioplasty in critical lower limb ischemia. This work is done under supervision of Dr. Professor 𝗔𝗀𝗃𝗃. Professor
Your voice, please.
Yes. This work is done under supervision of Professor 𝗔𝗀𝗃𝗃𝗀, Professor of Vascular Surgery at Mansour University, Professor 𝗔𝗀𝗃𝗃𝗀𝗃 Professor of General Surgery at Mansour University, Dr. Amr Mohamed 𝗔𝗀ه Lecturer of Vascular Surgery at Mansour University. CLI is a persistent recurring ischemic wrist pain for at least 2 weeks, ulceration or gangrene of the foot, toes, and ankle, systolic pressure less than 50 mm mercury or 2 systolic pressure less than 30 mm mercury. CLI usually requires the presence of severe arterio-occlusive disease at 2 or more levels, limiting the flow via collateral circulation, resulting in profound distal ischemia. High risk of limb loss is inevitable in absence of revascularization. Risk factors include age, smoking, diabetes, hypertension, hyperlipidemia, obesity, sedentary life, and hyperhomocystinemia. Diagnosis: first, history taking, onset of the complaint, progression of the disease, physical examination, exclusion of presence of aneurysms, palpation of femoral, popliteal, and distal pulse, laboratory investigation, CBC, serum creat, and INR. Radiological investigations include duplex scanning, computed tomography, angiography, and magnetic resonance angiography. Aim of the work: assessment of single tibial artery angioplasty in critical lower limb ischemia, patients Rutherford 5 and 6, and compare it with multiple tibial angioplasty. Primary outcome is wound healing. Secondary outcomes include patency rate, limb salvage, and 30-day mortality. Study design: prospective observational study. Sample size: 110 patients admitted to vascular surgery department at Mansour University between June 2020 and May 2021. Inclusion criteria include patients with critical lower limb ischemia with isolated single or multiple tibial artery lesions, Rutherford 5 and 6. An intervention include percutaneous balloon dilatation angioplasty. Patients were classified into 2 groups, single vessel and multi-vessel groups. Outcomes: as said before, primary outcome, wound healing. Secondary outcomes: primary patency, amputation rate, and 30-day mortality. Exclusion criteria: severely infected foot, patients with known history to dye allergy, patients with severe renal impairment, and patients with proximal vessel disease, whether aortoiliac or femoral-popliteal. Follow-up period included wound size and duration of complete healing, ABBI at 4 weeks, 3 and 6 months. First case: it's a 60-year-old male patient, diabetic, hypertensive with right lower limb CLI, other 4-6 with heel ulcer. Intraoperative angiography of the arterial tree of the right lower limb. We have done dilatation to the posterior tibial artery, and this is a follow-up of the tissue lesion of wound after debridement and revascularization at 1 month and 3 months. Second case: it's a 65-year-old male patient, diabetic, hypertensive, smoker with left lower limb CLI, Rutherford 5 and 6 with toes dry gangrene. Intraoperative angiography of the arterial tree of the left lower limb shows dilatation of the posterior tibial artery after angioplasty and continuation in the foot. This is the wound after debridement and revascularization at 4 weeks. Third case is a 58-year-old male patient, diabetic, hypertensive, cardiac, smoker with the right lower limb CLI, other 4-6 with big 2 dry gangrene. Intraoperative angiography reveals dilatation of the anterior tibial artery and continuation in the arch. This is the wound after debridement and revascularization at 4 weeks. Fourth case is a 60-year-old female patient, diabetic, hypertensive with left lower limb CLI, ulcer on the medial side of the head of big 2. Intraoperative angiography reveals dilatation of the anterior and the posterior tibial artery, and this is the wound at 1 month after revascularization and debridement. Fifth case is 63-year-old female patient, diabetic, hypertensive with left lower limb CLI, Rutherford 6 with infected heel ulcer. We have done angioplasty to the anterior and the posterior tibial artery, and this is the wound after debridement at 1 week, 1 month, and 3 months.
Dr. Ahmed, can we move on to your results and presentation because you're running out of time?
This is the demographics of the
Actually,
patients.
run out of it.
single vessel and multiple vessel. This is the outcomes. From the included outcomes, we have seen that there is no significant difference, statistical significant difference between the single and the multiple vessel groups regarding wound healing, amputation rate, and the 30-day mortality. Summary and conclusion include that single vessel angioplasty is safe and effective method, provided that we provide a continuous pulsatile flow to the foot to ensure wound healing. Thank you.
Thank you, Dr. Ahmed. And I have a question for you. The first is the term single vessel angioplasty. This is by design, or you just do angioplasty to the available vessel if it is only a single vessel?
Well, in the single vessel group, we have tried to do multiple vessel angioplasty, but the other two vessels, we have a total occlusion of the other two vessels, so we rest with one vessel angioplasty.
But if you had the option to do multiple vessels,
we would do it.
Okay. And the second thing, are you guided by the angiosome concept, or
no?
whatever works for you?
Yes.
Okay. Thank you.